लेनिन सर मुझे
डॉक्टर
फोन
लेनिन,
करे, मैं बात कर लेता हूँ। सर का फोन आ रहा था, मैं उठा नहीं पाया।
गुड इवनिंग डॉक्टर अतुल जाम्बेकर।
गुड इवनिंग सर, गुड इवनिंग।
गुड इवनिंग।
गुड इवनिंग अतुल।
हेलो डॉक्टर अतुल।
Good evening, good
डॉक्टर
evening.
लेनिन आ गए।
गुड इवनिंग।
Hello, Dr.
Good
Lenin.
evening, sir.
Good evening.
गुड
प्रिंस
इवनिंग।
लेनिन आ
गुड
गए।
इवनिंग डॉक्टर लेनिन।
प्रिंस लेनिन।
यस,
I'm here.
सर
द किंग,
गुड इवनिंग सर।
नॉट द
अरे
प्रिंस।
रही राजकुमारी इज प्रिंस
हाँ
ना,
जी।
बट
Good
लेनिन वाज
evening.
लेनिन वाज ए प्रोलेटेरियन।
Mixture of both.
यस,
अलीम शुरू करें।
Just a moment, sir.
मेक मी को-होस्ट। चिंतन मेरे को को-होस्ट करो।
So, sir, we can start.
Yes, we
Actually,
can start.
the introduction slides are not there yet. The person who was supposed to, yeah, it is just there now. Just a moment, sir. Just download the introduction slides and then we can start.
I am not co-host. If I am muted, I cannot unmute.
I'll make you co-host, sir. Allow participants to mute themselves. So now we can go to the slide share. So, share. I hope the slides are visible now. So, my great pleasure to once again welcome you all to this 171st episode of Thursday Musings. Today we'll be talking about OST. What is the practical problem that we face? What are the clinical considerations that we should have in mind? And we have none other than Dr. Atul Ambekar with us for this program. Everyone will be on the mute mode. The questions will be invited in the chat box. They will be taken up with the presenter. The session will be recorded and put on our YouTube channel. So my pleasure to hand over the session to Professor Dr. Tufan Pati sir. Sir is the chairman of this program. He has been guiding us. He has been stabilizing us, and whenever me and Amrit are going wayward. Sir, over to you. I'm not reading your introduction. And I'm unmuting you, sir.
So I could not unmute myself so far. Aleem had blocked me.
No, sir, I am unmuted you.
Okay, thank you very much, Dr. Aleem. Please
Yes.
proceed. No, we have
Yes,
got
yes.
our moderators, Dr. Aleem Siddiqui and Dr. Amrit Patujoshi. who are there from the very beginning, our vibrant moderators, both Professor of Psychiatry and eminent persons of Indian Psychiatric Society, held many offices and have many very good research practice and organizing ability. Over to the next slide. Dr. Ashwin Mohan. Welcome, sir. Dr. Ashwin Mohan has completed his MD Psychiatry from PCI in 2000. He has done his PGD MLE from NLSUI Bangalore in the year 2016. He is a senior practitioner in Chandigarh, having his own clinic. His major area of addiction psychiatry, forensic psychiatry, mental health policy and law, and advocacy. He is currently an EC member of IAPP, EC member of APSI, co-chairperson of IPS, addiction psychiatry, specialty section. Welcome, Dr. Ashwin Mohan. Our other chairperson is Dr. Rajkumar Lenin Singh, the Prince Lenin Singh from Imphal, Professor, Department of Psychiatry, ROMS Imphal, President of East June IPS, President IMA Manipur State Fund, founder of Share and Care Imphal, area of interest, substance use disorder, community psychiatry and adolescent mental health. Welcome, Dr. Lenin Singh. From here onwards, the session belongs to you. Someone will introduce our speaker, Dr. Atul Ambekar, the other topic, and we proceed. And over to you, our respected esteemed chairpersons.
Good afternoon,
Yeah.
or good
Good
evening,
afternoon.
rather.
Good evening.
So your voice is breaking a bit.
It's a
डॉक्टर लेनन आपकी आवाज कट रही है
wonderful opportunity for me. Is I would like to can I be audible now? Am I audible?
Yes, sir, you are now.
Okay. I'm privileged to introduce today's speaker. Dr. Atul Ambekar is a professor in NDDTC, AIMS, New Delhi. Special interests are epidemiology, drug policy, harm reduction, opioid substitution therapy. Secretary General of Addiction Psychiatry Society of India, in short, APSI. More than 100 publications in papers in peer-reviewed journals, books, manuals, and monographs. Resource person, expert for UNODC, UNAIDS, WHO, and INCB. Principal investigator in National Drug Use Survey in 2019. BMJ South Asia Award 2016, Non-Communicable Disease Initiative of the Year. And Venice International Medical Award in 2019, Excellence in Psychiatry. And this is not all the laurels he is helping under his belt, but we will be listening to this excellent orator, as well as he has done an extensive research in the areas of his interest. So I hand over it to Asim for carry on the next part of the
Thank you so much.
program.
So it's my privilege, actually. Thank you to the organizers for inviting me as a chairperson. It's my real privilege here to be the chairperson of this session. Dr. Atul and Dr. Lennon both are dear friends, and actually I find this a good opportunity to interact with them. And again, Dr. Atul is a very, very well-known figure, and he doesn't really need any introduction in as far as drug addiction and other issues related to addiction are concerned. And most importantly, he's an excellent speaker, very clear, very, very erudite, and he's one of the few people who can convey the correct message to people, to the audience and to participants. So I think he's the right choice for this kind of a talk. Now, just without going into too much detail, OST we have is a very it's a very hot topic, and not for the right reasons always. There have been many problems related to OST, many misunderstandings, many misconceptions with regard to OST. And I'm not talking really about the legal and other ethical issues with regard to OST, but even the clinical issues. Most people don't even know how to actually administer OST, how long, how often, what is the dose, when to do it. I mean, there are so many such issues, and I find that in my practice here, and when I encounter people, you find two kinds of patients. One who will only take OST without bothering to actually meet the doctor, and there is an other kind who is completely aversive to taking OST because of many myths and misconceptions. They completely means the first sentence they come when they come to the clinic is that I don't want to take that medication for whatever reasons. And when you talk to them in detail, they come out with all kinds of reasons which are, in a sense, very baseless scientifically. So, without much ado, I'd like to invite Dr. Ambekar to start his presentation, and then we'll take questions later on. Thank you so much.
Good
Sir,
evening.
Dr. Atul? Yes.
Namaskar. Thank you very much. All the organizers of today's program are very good friends of mine, and so are both the chairpersons. They are, in fact, collaborators in many things that we have done together. They are my, as I call it, partners in crime. So it's really no surprise that they have spoken so nicely about me. If given an opportunity, I will also speak very nice things about them. So this is how friendship works. Everything which has been said. Please take it with a large pinch of salt. That's one. And secondly, thank you very much once again for giving me the opportunity to discuss with all of you on one of my favorite topics, that's opioid substitution treatment. And today I'll be speaking about the clinical and practical considerations of this treatment. I hope now my slides are visible to everyone.
Yes, sir, they are.
Right. So basically, there are a few disclosures. I do not have any conflict of interest to disclose. If inadvertently some brand name appears here, or if I say it it's not used in any pejorative sense, nor as any promotion. There is another disclosure I want to make. These slides, this presentation, I have done many number of times. So those of you who are expecting something new, I'm very sorry. I will have to disappoint you there. But then, as Dr. Ashwin said, the topic still remains hot and still remains important for all of us to discuss and learn from it. Particularly among the colleagues who have not been familiar with this topic in so many details earlier, they, I suspect, may find something useful, something thought provoking, and something worth discussing. Because the challenges regarding providing this treatment to our patients, they still continue to remain fresh for us every day. And hence, despite the repetition of the topic, repetition of the message, it remains relevant forever. So what I will do today is I will give a brief overview of managing opioid dependence. I'll focusing more on the outpatient setting management. That's the setting where most of us operate. And I'll focus on clinical and operational both issues. Some people may find that I have done less justice to clinical and more to operational, but that's by design. There are plenty of other resource materials available on clinical practice guidelines on how this treatment must be provided. So we may not go into the micro issues of clinical management. We will try to focus as much as possible on some of the practical aspects. So to begin with, what opioids? They come in variety of forms like opium, heroin, a wide variety of pharmaceutical products. And the important thing about opioids is that despite being available as natural, synthetic, as well as inside our bodies in the form of endogenous opioids, they are very, very effective painkillers. In fact, one of the best painkillers known to humankind. Simultaneously, they also happen to be euphoric and addictive. So, on one hand, while they may cause problems of dependence or addiction to people, but they also serve and have been serving very useful purpose medically. So, as a category of drugs, as a category of substances, opioids need not be seen only as villains. They have actually been heroes and heroine, in other words. But once someone develops addiction or dependence on opioids, this is how their life actually looks like. their entire time of the day is spent either in buying and procuring drug, using them, experiencing the high, experiencing the effects, recovering from the effects of the drug, and then since they suffer from very severe and distressing withdrawals and craving, the cycle has to be repeated again. So this is how among all other dependence producing drugs, opioids have this particular propensity of causing very severe withdrawal and very strong craving. That makes it very difficult for people to remain occasional users of opioids, particularly opioids like heroin. For instance, alcohol, we all know it's quite possible to remain occasional users of alcohol. Many of us are. But in case of opioids, that kind of lifestyle, that kind of practice becomes difficult for people. And since their entire life is revolving around taking opioids and recovering from its effects, and then again seeking opioids, they hardly have any time to focus on their family, social, occupational issues. And since opioids happen to be illegal, particularly drugs like heroin, they are very expensive, and hence, to meet the requirement, people sometimes also have to indulge in illegal criminal activities to finance their drug habits. So in short, it's really a very severe consequences of addiction, which we see among people with heroin dependence. Now, what makes this heroin actually such a dependence producing drug is its ability, or all opioids, in fact, all acting opioids, is their ability to lead to very distressing and painful, though they are rarely fatal, acute opioid withdrawals. So as soon as stop taking opioids, they start experiencing severe, distressing, painful withdrawal symptoms, which rise. They reach at their peak at around second to third day, 48 to 72 hours. Then, if no opioids are administered, whether legal, illegal, of any kind, these acute withdrawal symptoms start falling down. So within about 2 weeks, these acute opioid withdrawal symptoms, they come down. What kind of withdrawal symptoms they are, as this picture shows and as this list shows, they are very, very distressing. There is pupillary dilatation, running eyes, running nose, yawning, severe pains and aches all over because opioids are great painkillers. And as a method to understand and remember them, it leads to opening of all holes of the body. So for about few days to few weeks, this person remains in a very distressing shape, though they do come down after about 2 weeks or so. But is the story over after this 2 week period is over? Unfortunately, no, because what follows is a period of protracted or post-acute opioid withdrawals for many weeks to many months. People may experience symptoms such as muscle aches and pains, difficulty in sleep, sexual dysfunction, particularly premature ejaculation experienced by men, a sense of anhedonia, not finding pleasure in anything. And all of these symptoms inevitably lead to relapse in a large majority of population. So, in other words, even if you are able to somehow magically take care of acute opioid withdrawal symptoms and leave people like that, it's likely that about 80 to 90% of them relapse within next few months, which makes opioid dependence a chronic relapsing disorder, just like other non-communicable diseases. Very iconic research milestone paper by McClellan et al., which they conducted for the purpose of insurance coverage for drug dependence. It actually showed that the rates of relapse are quite similar across many drug dependence, depression, asthma, all of them would require long-term treatment. A short-term treatment for an acute episode would inevitably lead to relapse in all these conditions. And hence their argument was even drug addiction should receive insurance coverage, just like it's available for diabetes or hypertension, etc. Message for us is that we cannot leave our patients just after providing a few days treatment. Their illness is such that if they do not receive long-term, they inevitably relapse. Now, when people with opioid dependence, they present towards in outpatient clinics, there are some unique features which we found with this disorder. One is that in opioid dependence, the denial, minimization, which we often see with alcohol dependent patients, is much less. In fact, on the contrary, quite a few patients of opioid dependence would engage in hyper inflating their severity of opioid dependence. They would try to project their problems as much severe than they actually are. Also, we very often find the involvement with criminal justice system because, as I said, people have to engage in criminal activities. If this is iatrogenic in origin, many people in our country, when they suffer from any pain condition, go to a general practitioner who very often provide them opioid analgesics, either oral or injectable. Fortrin Finargan is a very common prescription in general practice, primary health care, and hence some of these people may develop iatrogenic opioid dependence. And in such cases, we can find physical comorbidities as well. And these physical comorbidities can be found often as consequences of opioid dependence as well, particularly if people are using opioids by injecting route, when there is high risk of blood-borne virus like HIV and hepatitis C. In fact, in India, people who inject drugs is the high-risk group with high prevalence of HIV compared to other high-risk groups such as female sex workers or men who have sex with men. So how do we manage this condition? The primary management of opioid dependence happens to be pharmacological. And among pharmacological strategies, there are strategies such as acute withdrawal management, which is a misnomer, but we call it detoxification. And this may be then followed by antagonist maintenance treatment. These forms of treatment, the only detoxification or detoxification followed by antagonist maintenance, have high rates of relapse and hence lesser acceptability among patients. In general, in terms of the outcome, as well as in terms of patient own preferences, agonist maintenance treatment has far better evidence base as compared to only detoxification. Dr. Ashwin did point out that there are many patients who would come and say that I do not want that sort of treatment. The reason many of these patients are averse to taking agonist maintenance treatment is because of the misconceptions they have or the prior experiences of them received this treatment elsewhere, or the cost of treatment which they may find prohibitive. So some of these reasons may be there, but overall across the world, the preference for patients is much higher among patients is much higher for opioid agonist maintenance, and similarly the outcome has been much better. Very briefly, we'll talk about detoxification or the initial phase of treatment. That's treatment of acute withdrawal, where we just treat their withdrawal symptoms. We also spend some time and efforts on assessing their health and psychosocial complications, also engage them in a good therapeutic relationship, and which we do primarily by pharmacotherapy, for which medicines are available. I come to them. Question often arises in people's mind is, where should this acute opioid withdrawal treatment be carried out? The truth remains that despite lots of misconceptions in the community, among policymakers, as well as among doctors, that treatment of drug dependence involves inpatient care, admission to a de-addiction center, only a small minority of patients, because of the indications which are listed here, they would require inpatient treatment. A large majority of patients will fit the profile of which is there on the left hand side of the screen, of mild to moderate dependence with decent psychosocial support, and hence patienting, even if the treatment you have chosen for them is acute withdrawal treatment or detoxification. In fact, the Cochrane reviews, talking of evidence based here, this is slightly older, but the Cochrane review has also definitely given this opinion. There is no available research to guide us about the outcomes or cost effectiveness of inpatient or outpatient approaches to opioid detoxification. In other words, acute withdrawal treatment of opioids can very well be done by in the outpatient setting, and that's what we also practice at our center at NDTC. What of therapy is useful for this purpose? These are the characteristics of a good female agent for treatment of acute opioid withdrawal. It should obviously treat withdrawal symptoms. It should be long acting to the extent possible, should be safe, should display a cross tolerance with opioids. Cross tolerance means, to the extent possible, on the top of your medicine, if patients are using heroin, they should not be experiencing any benefit, any high, any pleasure. And these medicines should have lesser dependence potential of their own. And of course, they should be easily available. And the medications which fit this bill, all these criteria, happen to be agonist medications like buprenorphine or methadone. In India, in parts of the world, there has been a practice in the past of using non-opioid medications like clonidine for this purpose. With the availability of agonist medications like buprenorphine, I do not see any reason why clonidine should be used for this purpose, unless there are some very compelling reasons for this. Also, which can be a money minting practice in some circles of use of subjecting patients to ultra rapid opioid detox by subjecting them to anesthesia, either partial or general anesthesia, and taking care of all their opioid withdrawal symptoms, thereby shortening the period of detoxification, is an absolute no-no. The IPS guidelines clearly say that this is not recommended. So essentially, what we are talking about is using agonist medications like buprenorphine or methadone, because there is strong evidence base behind using them as compared to other approaches. Agonist maintenance like buprenorphine or methadone have been found to be much more effective, and methadone and buprenorphine are probably equally efficacious. In our country, buprenorphine has been available for a very long time. Methadone is relatively recent. In at our center a few years ago, we did conduct a randomized double-blind, double-dummy placebo-controlled trial. So here in this study, when we conducted, patients received placebo for both oral placebo as well as sublingual placebo, comparing because we're comparing buprenorphine and methadone tablets, and we found that efficacy was almost same on all outcome parameters. My student Dr. Anil Shekhawat, a DM addiction psychiatry, he conducted this. Also important to remember that psychosocial treatments must be treated patients along with pharmacological treatment while we are treating acute opioid withdrawal. With psychosocial approach, again, there is no clear evidence about this. But if you are providing people only acute opioid withdrawal symptoms, must remember that relapse is the rule rather than exception. More importantly, in the red colored font, the second bullet, there is evidence that there is high risk of mortality among people who successfully complete detoxification. Can you see the irony here? If patients are unsuccessful in detox, which means if they relapse, there is not much risk of their of death and overdose. Why this occurs? Because after detoxification is over, people lose their tolerance, and as opioid dependence is a relapsing disorder, if they relapse and they happen to use the opioids in the same dose which they were using earlier, it happens to be then overdose for them because they have lost tolerance, and hence risk of overdose and mortality. So this is something we must remember, and hence whenever we are providing only acute opioid withdrawal treatment, all patients must receive these 5 important points. They must understand that treatment actually begins after detoxification. It doesn't end at detoxification. Detoxification is just treatment of withdrawal. The real struggle of remaining away from opioids begins after that. There remains a risk of relapse, and hence patients who are aware of this risk, they are much safer as compared to those who are in a sense of bravado and displaying very high degree of motivation. They should always remain aware of protracted withdrawal symptoms. It's our duty to tell them that for next few months, you may suffer from these symptoms. Please find alternative coping strategies. The risk of overdose, they must be made aware of, and they need to understand that they must come to us immediately if they relapse. So having said that, what after detoxification? There are 2 approaches. There may be antagonist maintenance. We talked about it, and today also I will talk very briefly about it. Antagonist maintenance, basically, which means using something like naltrexone. That's the only antagonist which we have. One tablet of 50 milligram per day can work very well in patients who have this kind of profile, a relatively shorter duration of opioid use, who are not using opioids through injecting route. In other words, people who have a lesser severity of opioid dependence, or those who are using low potency opioids. So all in all, people with less severe opioid dependence, who have good psychosocial support also, who are engaged in more of a white collar job, as opposed to a job which requires manual labor, more exertion, because then because of body ache, the body's opioid requirements are higher. This is the profile of patients in which naltrexone can also work very well. That's what our clinical experience, as well as the whatever little research which has been conducted, it shows. Health professionals, if they happen to be suffering from opioid dependence, they show very good results on antagonist maintenance. And then I come to the major approach for treating opioid dependence, which is agonist maintenance treatment or opioid substitution therapy or treatment. It must also be understood that if in the initial assessment we decide that this patient is a fit candidate for agonist maintenance treatment and not detoxification, patient need not go through the phase of acute opioid withdrawal. Patient can directly move from day one itself to agonist maintenance treatment. No, from day one itself. What exactly is the philosophy? Again, I have repeated this hundreds of times. I'm not from repeating it again. If a person who is suffering from opioid dependence, that means the person is using something like heroin, which is illegal, which is medically unsafe, more importantly, which is short acting, and hence it requires to be taken 3 to 4 times a day. Sometimes it is taken by smoking route, sometimes by injecting route. In the life of this person, if other than heroin, we give substitute of heroin, such as an agonist medication like buprenorphine. And what kind of medication is buprenorphine? Legal, much safer than heroin. Most importantly, long acting, hence need to be taken only once a day and deliver a medical setting along with psychosocial rehabilitation, counseling, overall medical advice and supervision. That actually is the philosophy of agonist maintenance treatment. So, what does the term substitution here mean? What we mean, what we should understand and explain to our patients as well as the general public also. Substitution here does not mean that one addiction in patient's life has been substituted by another addiction. Substitution is occurring at the level of receptors. A short acting illegal heroin is being substituted by a long acting, safer partial agonist like buprenorphine. It's not substitution of one addiction by another in patient's life, but substitution of one agent by another agent at the level of certain patient. That's very important to understand and to others. Let's revisit the circle which we were talking earlier, which maintains opioid dependence and which compels our patients to take opioids every day, multiple times a day. If we are providing them opioid substitution treatment in the form of buprenorphine, their withdrawals, their craving that is taken care of, and hence they now have all the time in the world to focus on their family, their social, occupational responsibilities. They don't need to spend so much on drugs, and hence, and absolutely, they do not need to inject. So they are protected from those consequences as well. So, in general, putting this on treatment really becomes transformational for many patients. And there are people who have provided this treatment to their patients can provide this testimony to us. How exhilarating is the experience of seeing some patient doing very well on this treatment. What are the medications used? We will talk largely of buprenorphine, but methadone is also a medication commonly used for this purpose. Both of these medicines are long acting, provide good relief from withdrawal and craving, safe for long term use. Methadone is a pure agonist, have some complexity in terms of how do you build up the dose. It's older and cheaper as far as the international market is concerned. In our country, ironically, buprenorphine has been there for a long time, which is used by sublingual route, partial agonist, which contributes to its safety. Across the world, buprenorphine is relatively newer. For us in India, buprenorphine is the treatment as far as agonist maintenance treatment is concerned, because methadone is only available at a less than about 2 dozen sites in India. Most important benefit provided by medications like buprenorphine or methadone is their long acting nature. In case of buprenorphine, it's also their partial agonist nature. What happens is, if someone is taking heroin, depicted here by the yellow line, they are going through the phases of intoxication or high or withdrawals about 3 to 4 times a day, which necessitates taking this drug like heroin multiple times a day. If you put them on a long-acting agonist, they neither suffer too much of a high, neither suffer of too severe withdrawals. You just take it once a day, and a large duration of time of the day is spent in a comfortable state, neither in a high nor in withdrawals. That makes people able to and hence more functional. Very briefly, coming to some of the clinical practice guidelines for buprenorphine, what we need to remember is the first dose of buprenorphine must always be provided when the patient is in withdrawal symptoms. If patient is under the influence of heroin and we give them buprenorphine, patients will have precipitated withdrawal because buprenorphine has higher affinity for receptors. So if patient's receptors are already saturated by heroin and you take buprenorphine, the partial agonist, will replace heroin and sit on the opioid receptors. Thereby, overall opioid effect will go down and people will experience precipitated withdrawal. They will say, kya bekar dawai hai, right? They would not like the effects. On the contrary, if they are in withdrawals and they take 1 dose of buprenorphine, they will find relief because after all, it's an agonist and hence they would like this medicine. So always begin when patients, there is at least a few hours gap, preferably a 24-hour gap after taking their last dose of heroin or whatever opioid they were taking. In clinical practice, we usually initiate with 2 milligram, 1 dose. We observe for some time, say about 1.5 to 2 hours. And if required, we give them one more dose. We do this by trial and error method and are expected to reach patient's optimum dose within next 3 to 7 days. Now here we must remember and we must explain to our patients as well. Unlike many other medicines which have a fixed dose, in case of buprenorphine, everybody's requirements may be different. So it's actually by trial and error and by best clinical estimate that we can determine the dose for a patient. And for this, patient's cooperation becomes extremely important. So what happens? You give patients a particular dose, call them again and ask them, how are they doing? Suppose after their last dose, they say, doctor, I was okay when I left your clinic, but by evening I started experiencing craving or withdrawals once again. That means they were under medicated. You need to increase the dose. If patients report that I was sedated, I was drowsy throughout the day, I had severe constipation, that means their dose is higher. We probably need to tinker and reduce the dose slightly. If patients do not report any of this, then they are properly medicated. So how do we determine optimum dose? Number one, patient should not have any side effects. Patient should not experience withdrawal or craving. Third point is most important, which I am coming to now. Patient should not experience high if they happen to use heroin on top of buprenorphine. Your buprenorphine should be enough to saturate all opioid receptors, so there is no scope for heroin to act. So that's exactly the optimum dose which we should aim for. And in general, that dose on which the blocking effect of heroin is experienced is higher than the dose required to take care of withdrawal or take care of craving. So for example, 4 milligram is enough to take care of withdrawals. That means about 6 milligram will be required to take care of craving also completely, and 8 to 10 milligram may be required to take care of the blocking effect of heroin. And that's the dose we should aim for. So the dictum here is not lowest possible dose. Dictum here is optimum dose on which no craving, no withdrawal, no side effect, and no effect of heroin if patient takes heroin on top of this dose. Once this optimum dose is achieved, we need to continue and maintain the patients for as long as required. Really no fixed duration here. Many months, many years this treatment may be required. Throughout this period, compliance must be ensured. We should monitor clinically, if possible, by therapeutic, by the drug screening also, urine drug screening also, whether they are using opioids or any other drug on top of it, and efforts about rehabilitation, reintegration, psychosocial interventions that must be provided. Question will often be asked by the patients or their family, doctor, how long this treatment will continue? As I was saying, there is no fixed duration, but we can't give this answer to our patients. So in practice, what I have found useful is to tell our patients that less than 1 year, it's unlikely that this treatment is likely to be effective for anyone. So in your case, we are talking of at least 1 year of treatment. As the time passes by and we reach the 1 year, we will discuss once again whether the time is right to discontinue and terminate this treatment or not. If required, it may be required even for longer period. Because actually the treatment duration is decided by whether the treatment goals have been attained. And the treatment goals may also be shifting. In the first few months of treatment, staying away from heroin may be a treatment goal. Then finding a job may become a treatment goal. Once a job has been found, then getting a good bank balance may be your treatment goal. Then helping sister's wedding and contributing to it financially, that may be the treatment goal. So as I was saying, our treatment goals are not limited only to staying away from opioids, but also about functional recovery and rehabilitation. Only when these treatment goals have been met, that's when we can consider discontinuation, a slow taper involving many weeks, and which may be followed by antagonist treatment for few months to ensure that patients do not relapse. Many of these evidences as well as the suggestions, recommendations are adequately described in the IPS treatment guidelines, and here OST, this form of treatment has been described by IPS as the first choice for long-term treatment of opioid dependence. We must also remember here that what actually works in the opioid substitution treatment is the 4Ds, 4 dimensions which contribute to the effectiveness. What are these 4 dimensions? One is the dose. Optimum dose is essential. Second is, as I was saying, duration. In general, longer the duration, better the outcome. Then delivery. How are you delivering this treatment? The organizational issues. How easy or difficult it is to get their medicines for the patient. Whether you are providing adequate degree of supervision, psychosocial counseling, ensuring compliance or not. And the overall direction of treatment. As I was saying, treatment direction is about focusing on the functional recovery, rehabilitation, and not just staying away from opioids. So, if we remember all these 4 Ds, dose, duration, delivery, and direction, then this treatment is much likely to be successful. And continuous psychoeducation, engaging the patients and their family becomes very important for treatment. But and now I am coming to some of the other concerns which I often experience in our practice. This tablet has potential for diversion and injecting. It's partial agonist, it's safe, much less high, all good, all accepted. It's not a very good euphoriant. Street value is always going to be much lesser than heroin. Heroin continues to be available in Indian street. But we must remember, even these sublingual tablets can be dissolved in water or any other liquid like Avil, and they can be injected. And if they are mixed with other sedatives, they can provide a high pleasure euphoria to patients, and this risk always remains. Buprenorphine naloxone combination, of course, has much lesser risk, but it does not provide full protection. We have actually tested this using an experimental design in a blinded manner at our center. So, in other words, we must always remember these risks, and hence, if these tablets have unhindered access, if patients can obtain it very easily and can sort of barter it everywhere, it can harm some patients if they inject it, and there is a bigger risk of this treatment falling into disrepute, that doctor or this hospital or this center is actually dispensing an intoxicating drug, an addictive drug to its patient for money. That's the reason why there are so many controls and restrictions on availability of all opioid agonist medications, including buprenorphine. All of these medications, they are governed overall by the NDPS acts or rules, because they are either narcotic or psychotropic. Buprenorphine happens to be a psychotropic. And since they are also medications, they are also governed by drugs and cosmetic acts and rules. Problem here is even if while handling these medicines, even as a healthcare provider, if you commit a small mistake, which may be seen as a minor infraction, a minor violation
Nice.
of Drugs and Cosmetic Act, also attracts the provision of NDPS Act. So, and that brings problems to us as practitioners. The questions which often come to our mind, our professional colleagues' mind: can a psychiatrist prescribe buprenorphine? Can a psychiatrist or a hospital or a clinic dispense buprenorphine? What are the risks involved? Is it really worth providing this treatment? I will try to very briefly answer these questions. Some of these questions are also described in detail in this particular IPS guideline series, clinical practice guidelines on medical issues, published as a special supplement of IJP last year, in which we have written this chapter on medical legal issues with reference to NDPS Act, specifically for treatment of addicts. Coming to buprenorphine, a brief history. It came to India as an analgesic, and later on, its utility as treatment of opioid dependence was recognized. It was specifically given approval for treatment of opioid dependence in the higher strength tablets of buprenorphine 2 milligram and buprenorphine naloxone combination of 2 and 0.5. They have been scheduled in H or H1, and which means they come only with the warning that they should only be available with the prescription of a registered medical practitioner. The name is not psychiatrist there. Important point to remember. Any doctor can prescribe. Dangerous to take this preparation except in accordance with the medical advice. That should be an essential label for all H and H1 tablets. With buprenorphine, earlier there was a condition of this particular label, that this medication can be available only with the de-addiction centers or hospital with de-addiction facilities. This specific label was there only for buprenorphine or buprenorphine naloxone, which was neither a law nor a rule, just an internal communication between the Central Drug Standard Control Organization, that's FDA, to state drug controller or pharmaceutical companies. But on the basis of this, many doctors faced legal hassles and problems, and many of them actually were arrested as well. Finally, to cut the long story short, a lot of advocacy was undertaken by IPS, IAPP, editorials were published, specific guidelines were published. Association of Psychiatrists in Punjab directly met the CDSCO and presented its case. And finally, CDSCO in 2018 allowed that this medication, buprenorphine and buprenorphine naloxone, can now be provided to, this is the copy of that letter, to psychiatric clinics and hospitals, in addition to the de-addiction centers. So this actually paved the way for all OPD settings to be able to provide buprenorphine treatment. Please remember, the term used here is psychiatric clinic. It need not be only run by a psychiatrist, right? So a distinction which we must remember. Because of these reasons, this risk of diversion, etc., the precautions which we observe at NDDTC and we advocate for others as well, that if we are dispensing plain buprenorphine, we dispense only as dots, which means in front of us, patient comes every day and takes this medicine. Usually at our center, we insist that patients come to us every day, take these medicines in front of us, and after a few weeks of treatment with dots, they are then given buprenorphine naloxone as take home, and by with family supervision, and we try to limit the duration or number of tablets. So the balance has to be struck here between the benefits to the patient as well as risk of harms. Not an easy task, but we must work towards it if we are really serious about providing good treatment to patients and avoiding any kind of legal hassles. If you ask me individually, the ideal scenario about buprenorphine, it should not be available in pharmacies at all. It should be available only through some kind of recognized facilities. And these recognized facilities could be a wide variety types. They may be drug treatment centers or clinics, which may be in any setting, government, NGO provide. Treatment must be prescribed by trained doctors. Records must be maintained. There must be a monitoring and evaluation framework. As take home, only buprenorphine naloxone must be available and with some standard procedures. Help our professional colleagues, Indian Psychiatric Society has actually published, my my esteemed chairperson Ashwin Mohan is here, who has played a very stellar role in this, in producing these guidelines which focus on operational procedures. During coronavirus pandemic and lockdown, etc., we further relaxed some of these guidelines for our colleagues. What we must remember is these are nearly not legal documents, so it's not really a law. But if you are following guidelines and if you are harassed by a law enforcement authority, then if you can demonstrate that I was following guidelines by IPS, I was doing only what is written in my guidelines, that can provide some degree of protection to it. If you are found violating even these guidelines also, even though these are not law, so I'm not saying that violation should be seen in that spirit, but if you are going beyond the recommendations of your own society's guidelines, then obviously the protection becomes much more difficult. Coming back to these questions again, can a psychiatrist prescribe? Of course. Nothing stops any registered medical doctor from prescribing any of these medicines, including buprenorphine. Even an MBBS doctor can prescribe buprenorphine. But can any of us stock and dispense? Yes. Law permits us to stock and dispense buprenorphine to our own patients, which means we cannot honor someone's own prescription if we are stocking and dispensing it. The patient has to be our own patient who we are treating, and that's the situation where we can dispense this medicine to patients. And this applies to all the independent practicing psychiatrists as well. Coming to the final question, what are the risks involved? Is it really worth it? Well, doing anything, any kind of medical practice entails some risks that we know. If our practice involves handling these medicines which are specifically controlled by the law enforcement, then there is certainly a risk of being troubled by the law enforcement authorities. And uh, and being troubled here may be also of different degrees. Is there a risk of inconvenience? Yes, risk of some inconvenience in terms of someone asking you some specific questions, someone visiting your clinic or writing a letter to you, asking you to submit your records, etc. That risk is always there. Risk of actual harassment, someone threatening you, etc., is also there, but it is much lesser. If particularly if we are doing everything properly. Risk of arrest and jail, that also is there, but that risk is very minimal if we are providing all sorts of precautions. But it's not zero, right? So that's something we must remember. It's really like driving a car. Is there risk of road traffic accident? If I am sitting at my home, that risk is almost zero. If I'm driving my car in high speed without having a seat belt in place, rash driving, wrong side, the risk is much higher. If I'm observing precautions, the risk goes even lower. So we should always evaluate the cost benefit ratio here. But I will leave with this last message on this slide, that if a private psychiatrist or a government institution decides consciously that I will not provide this treatment, I will not doing this OST, what we are doing actually is ceding the space, leaving the space for the wrong kind of people to enter into the market. So nothing in the law, nothing stops a commercial entity, a SEDG type of person, to open what he calls a psychiatric clinic, employ any doctor, a psychiatrist or even an MBBS doctor, and start stocking and dispensing buprenorphine to people. If we want to avoid that, if we want that this treatment must be available in the right manner, then I see as psychiatrists as having this duty to provide right kind of treatment to our patients. If we find that in our locality, our area, there are a substantial number of patients who require this treatment. So for this to happen successfully, we all of us need to work together. We must always listen to our patients, engage them in our treatment. The pharmacists, the pharma industry, the regulatory agencies, all of us need to be on the same page, work together, and hence we must find forums of discussing this. To conclude, the ideological barriers, as I see among psychiatrists, they are slowly being dismantled. A few years ago, whenever I used to talk about opioid agonist treatment, about 1.5 decades ago, when I started doing this, I used to face much more resistance by our own senior colleagues. some of them would engage in very, very long and arguments with me about the approach which I am advocating, that you are advocating actually giving addiction and you are spreading addiction in the society. That has drastically come down. Acceptance of this treatment in our own community has increased manifold, and all credit goes to very wonderful senior colleagues. Many of them are sitting today in the audience. The exposure, training, clinical competence is rapidly improving. How is this happening? Because many educational institutions, the departments of psychiatry, they have started providing this treatment. So naturally, younger trainees get exposed to it. When they go out in the private or in government sector, they are much more than trained and sensitized about how to provide this treatment properly. Fear of unknown still persists, and the matter is not helped by one or two instances which we still keep encountering when our colleagues are harassed, even arrested and jailed by the doctors, jailed by the law enforcement authorities. We do not have all the details at our disposal to be able to comment on the propriety of this measure by law enforcement authorities, but the risk is certainly there. We can't really say to what extent our colleagues who have been arrested have been right or wrong. I suspect that there may have been mistakes from both the sides, from some of us and from the law enforcement authorities, who often are known to act in high-handed manners. And hence, the efforts to develop our own in-house systems for capacity building, mentoring, they must continue. At this moment, I do not see very systematic efforts by the professional societies on doing this on a regular, systematic basis. We can do much more in this, particularly in empowering and facilitating our members in providing this treatment, and importantly, continuing to engage in advocacy for legal and policy reforms. But the last point is important, our role as advocates, because these are the recent news items of last 3 weeks only. Uh, One in India Today, one in Tribune, and these articles are lamenting the fact that people are on buprenorphine treatment and they have not been withdrawn from this treatment. They continue taking this treatment. They should be happy that people are retained in this treatment, not taking heroin. Would they really prefer that people stop buprenorphine and move on to heroin, and all the illegal market then keeps getting strengthened? Who explains this to them? Many of us have been talking to media, have been writing in media, but I guess these side of advocacy efforts must continue on the banner of our professional societies very frequently, very regularly. That's where I'll conclude, ladies and gentlemen. Thank you very much for your patient listening. I'll be very happy to engage in further discussion on this topic. Thank you.
Thank you, sir.
Thank
Thank you.
Thank you. What a
Thank
wonderful
you.
presentation. Everyone was glued to the screen, sir. Thank you so much. Over to chairpersons for their opening
Yeah,
remarks.
thank you. Uh, Thank you, Dr. Atul, for a wonderful talk as usual. And I've heard many of your talks, and especially in the recent weeks, we've interacted quite a lot. uh, what I would like to say is that summarize some of these issues. And Dr. Lennon, with your permission, please. Uh, there are four kinds of challenges that we actually face when we are doing OST: ethical, legal, clinical, and challenges related to perception. So today I would like to keep perception, ethical, and legal challenges on the side and basically focus on what Dr. Atul has actually done is focus on mainly clinical challenges. I think that is where our younger colleagues might actually benefit, and because many of them have not done it and they would not understand what the issues are. I would say the problem starts basically with the terminology itself. What Dr. Atul has clearly mentioned that OST, opioid substitution therapy, is not substitution of one opioid with the other. It is at the receptor level. You are substituting or giving another medication in against a short acting drug like heroin, etc., and using that scientific basis to treat a patient. So that is what some our colleagues must understand, is that opioid substitution is at a receptor level one. That's very important. So the terminology itself causes problems, and therefore opioid agonist therapy is much more preferable, or MAT, what is used in the US, medication assisted treatment. Assisted, that also I'm not very, I mean, I'm not in favor of, but anyway, whatever they like to say, call themselves. But medication assisted treatment is preferable to OST, I would say. That is one important aspect. Uh, the other important thing that there are many things, and later on probably I'll ask some questions on my own to Dr. Atul, and so that we can clarify certain things. The second important thing is that there are 4 kinds of doses that are important. All opioids are analgesics, one. But understand that analgesic doses are different from treatment doses for opioid dependence. That is the second mistake which our colleagues make almost every time universally. And they sometimes think that if pain relief is done, then their job is over. That is not true. There are 4 kinds. First is analgesic dose. Second is suppression of withdrawal. Third is suppression of craving. And fourth is actually the dose which can suppress the use of other opioids. These are 4 different kinds of doses which are there. And we all normally stop at the first or second level, whereby we come to know that the opioid uh, um, withdrawal or analgesic doses are complete, and then it seems as if our job is done. That is not so importantly. Third, third mistake that we make is that what Dr. Atul has very elaborately discussed about is the goal of treatment. Often, till now, we consider abstinence as a goal of treatment, and we consider that if treatment is going on with medication, that means that the treatment is not complete. It is completely incorrect. Please understand is that what he has said about protracted withdrawal and a dysphoric state of mind, which is of the brain, which is there for months to years to come, is there. You like it or not, it's going to be there. So treatment has to involve something which will remove all those residual symptoms which are there in the brain for months or years to come. So abstinence is ideal, but not necessarily the goal. If it happens, it's great. But functional recovery is what we need to focus on. That is very important that our younger colleagues need to understand. With these few things, and there are lots of other clinical challenges which are there, I'll like to invite Dr. Lenin to for his comments, and then open the house for questioning. I mean the session for questioning. Dr. Lenin?
Yeah.
Yes.
Sorry. Close one.
Yes, please close one device. while it's doing it. Lenin sir, please unmute.
Sir switched off one unit, so that I think he was unmuted there.
Sorry. This was an excellent presentation from Atul as well, as usual. And it makes everything clear and very well explained to everyone, including those who are still in the practice. Dr. Austin also have explained some of the clinical challenges and the facts. Some of the challenges we come across in our clinical practice is that some of the clients, when we give the optimum dose, try to give the optimum dose, which is the most important policy to retain them as well as to give the quality of life and to reintegrate in the community. Many of them, usually the chronic ones who are using this substance for many years, they refuse to take the optimum dose and then deliberately take the lesser quantity because in the evening they want to on top of the buprenorphine they want to add heroin or some other substances so that they also enjoy euphoria or certain or the pleasurable activities together in the evening. So this is one challenge we used to come across. And still, as it was mentioned by Dr. Atul, that diversion is still going on. It is available in the market almost freely in double the price. So these are some of the challenges going on. And others have many of the questions Atul has explained. And hope we will have more clarity when we address the questions put up by our participants. Once again, it was an excellent presentation from Dr. Atul. So Dr. Ashwin, we will
Yes.
take the questions
Yes, sir.
from chat
I'll,
box.
I'll take the questions.
Please.
Organizers, can we take the questions?
Yes, sir, please, sir.
Yeah. So the first question is buprenorphine plus naloxone put together in ratio even 1:1 was unable to stop the euphoria of buprenorphine when diverted. Indian study suggests. Then what is the rationale to put them together still? What can be the practical reasons for shifting from buprenorphine to methadone?
Okay, so about buprenorphine naloxone, the idea behind this was that some amount of naloxone, if it is added to buprenorphine, people will avoid injecting it and obtain high. So this was actually more aimed at that market where predominant pattern of using opioids is injecting route. Most developed countries, Western countries, where we have raging opioid addiction epidemic, very few people actually use heroin by smoking or chasing route, like we see in India. In those countries, predominant pattern of using opioids happens to be by injecting route. Heroin primarily is being used, now fentanyl also, but by injecting route largely. In our country, we see heroin chasing as the primary route. So in those countries, the the adding naloxone reduces the risk of people diverting and injecting it, because the gradient between what they usually inject and the pleasure provided by buprenorphine naloxone tablets would be much higher. In our country, since most people use heroin by chasing route, injecting buprenorphine or even buprenorphine naloxone comparatively will give them some high. So this ratio of 4:1 is not very useful for India. In other words, in India, if people are injecting buprenorphine plain versus they are injecting buprenorphine naloxone, there will only be a slight difference in the amount of high or pleasure they are going to experience. So the risk of diversion and injecting, it remains high in India as well. But since the international standard is 4:1, that's what has been adopted in India as well. If we demand that we want higher strength of naloxone in our buprenorphine naloxone combination, we will have to provide logic to the industry, and then industry will have to convince the regulator to please allow us making manufacture of higher strength naloxone in fixed dose combination. And those questions will be uncomfortable because that will increase the cost. If we advocate for this, we will be seen as unnecessarily favoring the industry and increasing the cost of treatment. So all those complexities will come in. Suffice it to say that buprenorphine if we are giving as take home, plain buprenorphine should always be avoided. Buprenorphine naloxone is the lesser of two evils, but the risk of diversion and injecting still remains with buprenorphine naloxone, and hence important vigil must be maintained. All precautions must be taken for the same to avoid same.
Okay. Second is that if patient has protracted withdrawal, I'm only going to take mainly clinical questions, not legal and ethical ones. If
Yes.
patient has protracted withdrawal, how long to continue OST, and when can one start antagonist treatment?
Okay. The standard duration of protracted withdrawal is said to be many weeks to up to 6 months. There may be individual variations. There may be people who may complain of craving even after 9 months or even 1 year after their last dose of heroin. But usually about 6 months at least, most patients would experience protracted withdrawal. But the point to remember here is the idea behind agonist maintenance is not just to tide over the protracted withdrawal or abstinence. Idea here is to continue and maintain this treatment till the treatment goals are met. So protracted withdrawal is just one part. As I was saying, we must focus on functional recovery. So even if after first 6 months, the protracted withdrawal symptoms is over and your patient is protected from relapse, there may still be logic in continuing your agonist maintenance because there are other goals of treatment yet to be achieved. He is still yet to do a good occupation, saving some money. regaining the reputation in the society, regaining the trust of his neighborhood, and so on. So all these are important elements of outcome, not just taking care of the comfort of body ache or sleep, right? So as providing maintenance treatment, it's not just symptomatic treatment of someone's withdrawal or craving. It's actually about an aid to recovery of the individual. That should be the approach with which we should provide this treatment to our patients.
Thank you. So just to add, as to emphasize, one has to have the objective of why one is starting OST, whether it's withdrawal management or whether it is maintenance treatment. So unless your objectives are not clear, you will not be able to provide do justice to the treatment itself. Second, sir, naloxone 50 mg needs to be continued for how long? I'm sorry, it should be naltrexone 50 mg. Unfortunately, I mean, it must be
Typo.
maybe a mistake. Needs to be continued for how long? Of course, that's antagonist treatment, but briefly, sir.
Yeah. In again, as I was saying, there is no fixed duration of any of these maintenance treatment. Like buprenorphine, naltrexone also, since it blocks the receptors and acts by providing extinction of opioid use behavior. The idea here is their receptors will be blocked by naltrexone. If you take heroin on top of it, you will not experience any pleasure or high, and hence your need to take heroin that will go down. Usually, the protracted withdrawal abstinence period of about 6 months would be at least be required to continue. Naltrexone must be continued for this duration. But many of my patients have required naltrexone even for longer duration, 1.5 to 2 years, or even longer than this. So this can also continue for a fairly long period of time till there is risk of relapse. But remember, on naltrexone, there will be no symptomatic relief from craving or protracted withdrawal of any kind. It will just offer a protection from effects of heroin if patient happens to lapse or relapse again.
Thank you. Uh, so how commonly in your practice you have seen sexual side effects associated with OST, and how do you handle the same?
Right. So I do not provide OST to anyone who is opioid naive, right? So whatever side effects I see, they may not be only of buprenorphine, they may also be effects of patient currently not taking heroin. This is something we must remember. All the side effects which people say are specific to buprenorphine, none of these are specific to buprenorphine. These are effects seen in patients who have stopped taking heroin and now taking buprenorphine. So many of those effects, sexual effects which we are talking about, they may actually be effects of not taking heroin. So as a part of protracted withdrawals, if their buprenorphine dose is not adequate, patients may still continue to experience things like premature ejaculation. Having said that, it is known that chronic opioid use of both pharmaceutical kind as well as illicit kind does lead to a reduction in libido, a reduction in overall sexual desire and performance, in many cases, a reduction in testosterone levels as well. So that risk is always there, and one must be aware of this. Very often in my practice, what I have observed is that giving patients a choice, and not just about sexual side effects, other kinds of side effects as well. Something as mundane as constipation. Giving patients as choice. What would you really prefer? Uh, uh, Lesser of these side effects, or a risk of experiencing craving and some amount of withdrawal? Would you prefer rather be remain constipated, or would you rather face the risk of no constipation but a risk of experiencing craving and lapse again? And then patients are able to make that choice themselves. No, Dr. Saab, continue this dose only. I will manage my constipation. I will manage my sexual side effect. If the sexual side effect is of low erection or low libido variety, some amount of dose tinkering, reduction in dose, etc., that often takes care of these side effects. In some very rare cases, one may require specific pharmacotherapy for sexual side effects as well. So psychosocial intervention, psychoeducation, that takes care of many of these side effects including the sexual side effects.
Thank you. If a patient is on MMT, methadone maintenance therapy, and wanted to shift to naltrexone, how should one proceed?
Okay, this was not the topic today.
Yeah, correct.
Basically, methadone maintenance also methadone is a pure agonist, fairly long-acting one, gets accumulated in the body, so and hence the actions remains uh, for a very long time in the body. So it essentially involves very slow taper going which may last for many months to many years, and then patients can be put on naltrexone. The
Okay.
strategy of low dose buprenorphine, adding low dose buprenorphine while you are tapering for methadone, has also been described, because the partial agonist action of buprenorphine aids in slightly faster withdrawal, faster taper of methadone. But that's not really a topic for today. Perhaps we will require a more specific session on clinical practice guidelines involving methadone treatment.
Correct. If comorbid alcohol use is there, can we use OST?
Yeah. Uh, there is no
A practical question.
contraindication. Yeah, there is no contraindication of using buprenorphine if there is comorbid alcohol use. But if we are not treating alcohol use problems and providing only treatment for opioid dependence, we are doing a disservice to our patients. Also, in combination with alcohol and buprenorphine, the risk of some of the side effects goes up. So, ideally, if patients have alcohol use disorders, they must also be treated along with opioid use disorders with buprenorphine. As such, it's no contraindication. Alcohol use disorder is not a contraindication for providing opioid dependence treatment with buprenorphine. Ideally, both disorders should be treated.
I agree completely, and we encounter actually many patients who take alcohol in the night and take opioids in the morning, and they use OST and they're quite doing very well. In fact, of course, this should be educated to them that there is always a chance of an overdose if they take both together. This should be informed to those patients. Otherwise, there is no contraindication. In so many years, almost 23 years of practice, I have not seen really anybody getting into trouble with the alcohol use and this thing. But yes, as Dr. Atul has pointed out, one substance itself is not important. The second treatment for the other substance is also very, very important. Of course, depending on whether that person really wants to leave it or not. Okay. Can we increase the dose after a maintenance dose is established? Many patients ask for increase in dosage during working season to work harder.
Very, very, very valid point. Very valid point. Very commonly encountered situation. What we must remember here is, with change in season, change in environment, change in some amount of routine or lifestyle, our own body's tolerance to pain or fatigue, that gets altered. For that happens for everyone. Our appetite also changes, right? In some seasons we feel more hungrier than usual. In some seasons we feel more tired than usual. In some season pain strikes us more than usual, than other seasons. The same can happen with our patients of opioid dependence. If there is a change in their lifestyle, for instance, earlier they were not working, sitting at home throughout the day, and hence a particular dose was okay for them. Now they have started going out, perhaps working, more physical labor is involved. They get tired, fatigue, body ache, and body's endogenous opioid requirement is higher now. And that's the reason why they may request for a higher dose of buprenorphine. So there should always be a careful consideration of the case from all possible angles whenever such request is encountered. When we say patient's involvement in decision making about dose, that does not mean blindly prescribing and dispensing whatever patient is asking for, but a careful assessment and reaching the decision that yes, this patient perhaps requires a higher dose that can be tried, and that has to be a sort of a trial and error method. A more careful monitoring is required in those days when we have increased the dose. So these are some of the strategies which we employ at our clinics.
Thank you. So I will just add a little couple of sentences to that. Many of our opioid patients are extremely sensitive to pain, extremely sensitive to somatic changes in the body, and extremely sensitive to emotional changes in the body. In fact, any change they perceive, and as Dr. Atul has said, that most people tend to exaggerate the kind of problems that they face. It's both ways. They tend to exaggerate one, and they tend to perceive it much more than what others would actually do. So, a flexible dosing mechanism is actually preferable in such patients. Remember that your purpose is to prevent them from using illicit drugs. So, if you are not going to listen to the patient and give an extra dose during the period of, say, working or like, of hard work, or say farming or etc., you are probably liable to maybe opening him to taking illicit drugs on top of buprenorphine. That is something which we need to avoid. So a discussion with the patient is very important. Increase the dose temporarily if required. There is no bar. One should not be have a very rigid kind of a rule for that. Okay. Can Again, this is not a topic for today, but could you please elaborate the role of tramadol in management of opioid withdrawal? I think we can, there are lots of questions. We can keep this for some other time. Ideal way to manage, for how many days maximum can buprenorphine plus naloxone prescribed at one time? I think, Dr. Atta, this is a very,
It's a very, very pertinent, very, very important question, right? So again, there cannot be a law about this. Please remember, because if we make a law about this, any minor violation of this law will be a crime and will send us to jail, right? So it's best that this is not written in any law on how long can you prescribe. But please also take care of or think about a good clinical practice. As good clinicians, do we give a very long term prescriptions for all our patients for all other conditions? Do we tell our patients of schizophrenia or depression that take it for 2 years and then show me? Right? We don't do that. There is a reasonable degree of prescription duration, and after which we want the prescription to be renewed, patient to be re-evaluated, and prescription and dispensing to then take place. That's what we do for all the patients that we see: depression, schizophrenia, or bipolar, and so on. Similarly, for opioid dependence also, considering that we are dealing with a medication which is controlled, which is liable to be diverted, we need not have a very long duration of prescription. IPS guidelines actually, what Dr. Ashwin and I have written jointly, it actually says that an optimum duration of prescription is about 2 weeks for most patients. Prescription and dispensing is about 2 weeks. Of course, one has to strike balance between the total number of tablets a patient is taking. So 2 week dose, if someone is on only 2 tablets a day, would only mean 28 tablets at one go they are carrying. Someone is on 20 tablets a day, theoretically possible. So they would be on 280 tablets. So how many tablets would you be comfortable in someone carrying at one go, and looking at the risk of diversion, etc. So looking at all these factors, one must try to strike a balance between how frequently I want to call this patient. The plea is often taken by my colleagues working in the periphery, particularly those who are in private practice. My patients are coming from very far away, but then if our society is active, if our members are active, and all of them are providing, many of them are providing this treatment, it should be possible for the patient to get who requires treatment closer to them, not necessitating them to travel hundreds of kilometers every few days or few weeks. So in other words, always strike a balance between patient's convenience as well as the propriety of treatment. All of us would want our prescriptions to be honored, to be seen as by respect when they fall into the hands of our own colleagues, right? None of us would like our prescription to be ridiculed, laughed at, or us to be seen as with suspicion. So that kind of balance must be sort of maintained. I need not say more than this. I think.
okay. Is the efficacy of OAT, does the efficacy of OAT change if patient is using comparatively long acting illicit opioids like fentanyl? I think the answer is no, actually. But anyway,
No, 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 no,
Dr.
no, no,
Atul?
not
Hello?
Not yet. Most of the
Yeah, yeah,
evidence. Hello, am I audible? Yeah.
yeah,
So
yeah.
most of the evidence that we have from research is on heroin dependent patients, specifically on people with fentanyl dependence. Good evidence is yet to be documented, but I do not see a reason why buprenorphine or methadone type of treatment will not be effective for fentanyl. So I think that should be enough for
Yeah.
this answer as of now. Till we wait for better evidence to emerge.
If so, what Dr. Atul is saying is that every opioid is slightly different. So, if we go by rigid scientific standards, we need to evaluate OST for every single opioid, whether it is
Yeah,
poppy husk, whether it's raw opium, whether it's heroin, whether it's fentanyl or not. In general, our
yeah.
own experience and our own scientific understanding would say that it should work for all opioids. But if we go by rigid standards, then we should evaluate for every single opioid.
Right,
I think
right.
that is what Dr. Atul wanted to say. If a patient becomes comfortable on less than 8 mg, should we still increase the dose to 8 mg or more?
Again, as I was saying, our goal is not just making people comfortable, which means taking care of their withdrawals. Our goal is also to specifically target craving, for which a dose slightly higher than that controls withdrawal will be required. Our goal is also to block the effect of exogenously administered shorter acting opioids like heroin, for which again the dose required is slightly higher than that required to block craving. So if the patient is comfortable, just comfortable on 8 milligram, which means his withdrawal is taken care of, slightly higher dose will be required for craving, and even slightly more higher dose will be required for the blocking effect. That's what we are aiming for.
So, so what Dr. Atul is basically saying is that don't look at the dose at all. Look at the patient and his complaints and his symptoms. So if it's 2, 4, 6, 8, 10, it doesn't really matter. If he's reporting no craving and if he's reporting adequate control of withdrawal and all of that, then stick to that dose. 8 or 6 or 10 doesn't really matter much, really. So it's a very individual tailoring of dose. Can we advise OST for tapentadol and tramadol dependence? This is a very practical question because
Yeah,
we see a
and
lot
and
of
and you
pharmaceutical.
and you just answered it, right?
Yeah,
The decision about using agonist maintenance treatment is based upon the severity of opioid dependence of an individual, right? If you determine severity and duration, if you determine that the opioid dependence is severe enough and has been there for a long enough duration, then agonist maintenance is the preferred approach irrespective of the opioid people are dependent upon. On the contrary, if someone is taking heroin but only for 6 months, for in not a very high dose, that means their dependence severity is low, and in those cases you can possibly give a try of acute withdrawal management followed by naltrexone as well. So the point here is about severity of opioid dependence, not so much about which opioids people are using. So for instance, Dr. Kala always gives this example. uh, there is no beer dependence or whiskey dependence, right? There is alcohol dependence. Some people may use whiskey, some may beer, some may drink desi sharab, but it's essentially alcohol dependence we are talking about. So we discuss in terms of the total effect and severity, not the specific agent. So yes, the short answer is even for tramadol and tapentadol dependence, opioid agonist treatment is effective, must be used, because any day buprenorphine as a pharmaceutical product is much safer than tramadol or tapentadol.
okay. Last two questions, I think, and we will be running out of time. Sir, if we admitted a patient with psychiatric disorder who has in his possession buprenorphine, which was given to him by an OST center, can we continue buprenorphine to him without having license of it?
Again, a license to dispense buprenorphine is a state requirement only for some states, right? So in those states, this situation will apply. That if you are sort of not authorized by the state specific laws, to dispense buprenorphine, then you cannot dispense buprenorphine to the patient. The patient is carrying in their own possession if your clinic's laws, if your hospital's laws otherwise allow patients to keep in their possession whatever they like and whatever they want to take, then it's fine. But if your laws if you are specific about that in my hospital, I keep a track of what my patients are eating, what my patients are taking in terms of medication, then you should be very careful. Then it's a no-no. So if the local law says that you are not authorized to dispense buprenorphine, you have no business of dispensing buprenorphine if you are not authorized to do that. That's the simple answer.
Yeah.
To avoid any kind of legal hassle.
Okay, I will just add to it. Remember that the patient has been dispensed buprenorphine from another OST center. So the patient in himself, if he's continuing medication in your center, you've not dispensed it, you have no records of keeping it or anything like that, and you allow your patients to take the medication which is already on, then it is possible to continue that because you have not actually dispensed it or procured it in that manner. So there is a slight, I mean, demarcation, or we can say technical thing whereby you've not done it and he's continuing medication which has been given to him by some other place. So that is quite possible, although you are not authorized to dispense it. So there is a possibility where you might find that you can continue buprenorphine given by another center. So that is possible, but as Dr. Atul has said, this is a very gray area, and one can fall into trouble, one may not fall into trouble. It's a very dicey thing, but technically one can continue it because he's been continuing from another place, not from your place.
Yeah. So
And
you will
one
have to
last
you in
yeah.
this question, in this issue, you will have to demonstrate that the possession was by the patient, not by the hospital, right? And so you will have to specifically clarify that my hospital was not the one possessing buprenorphine. It was possessed by the patient. It was found with that patient, not with my hospital. But all these arguments will be made in the court, right? And this, you may get this opportunity to only present this argument in the court after spending a few weeks in jail without bail. So that's what I'm hinting at, right? All these arguments sound fantastic here, and I totally buy these arguments, right? But if someone books a case and it takes us to jail, uh, we may actually get this opportunity to argue only after spending a few days in jail. Some of our colleagues have actually faced this. So that's what I would ask all of us to be careful about.
Sir, if I may add one thing, uh, uh, there are many cases, many instances where people are in jail actually, and they have been in problem with the legal system. So, what are the things that one should do to avoid landing up there, to avoid legal hassles? So, a few brief points. How to avoid going to jail?
Right. If in general, as I was saying, if we are maintaining all our records meticulously, and our the magnitude, the amount of our practice is something which appears reasonable to anyone, then we are unlikely to fall in trouble. If someone says that I see 400 new patients of opioid dependence every day, and I dispense buprenorphine to all these 400 new patients every day, and this much is the consumption of buprenorphine tablets at my clinic, so there is obviously people will find will see this with a suspicion. So if the degree of our practice appears at the first glance from outside to be a reasonable degree of practice, कि हाँ डॉक्टर साहब, given the time which you sit in your clinic, you can really do justice to X number of patients. You can give the dispensing to as many patients. This is your pattern of utilization of tablets in your center. This is how you do your procurement. This is how you maintain your records. This is how the receipt of medicines and the money from the patient is maintained. If all this on the face of it is appears reasonable, then the risk of such harassment is far lower.
Uh,
In my
Okay.
interaction with law enforcement authorities, what they have told me is that they try to go after those settings, those situations where where things appear really out of proportion, right? If they find from the suppliers that suddenly at one particular clinic thousands of tablets are being procured by them and dispensed and claimed to be dispensed every day to hundreds of patients every day, then obviously they would say that एक डॉक्टर साहब इतने सारी दवाइयाँ इतने सारे पेशेंट कैसे देख सकते हैं दिन में, क्या जस्टिस कर पा रहे होंगे वो, कितना टाइम दे पा रहे होंगे अपने पेशेंट्स को. Those are the kind of arguments they have in their head. I'm not saying they are justified or not, but these are some of the things which invoke suspicion, which invite trouble. And then of course it's a matter of then legal arguments, battles in the court of law, going through the criminal justice system. Who ultimately emerges victorious is a different issue altogether, but the suffering which some of us may have to undergo for even for a few days, it's too much really. It's not worth it. So
Sir,
that's
sir,
why I always advocate for a very careful and balanced kind of
any
practice.
what precautions in maintaining the records? Any specific way of maintaining records so that it is clear to everyone later on?
Yeah, unfortunately, no. Unfortunately, what has happened is formats of these records, they have not been prescribed under the law, which at once is something good and at once something bad also. Why it is good? Because if there is a very specific format prescribed, then there is a small variation there, small infarction, small mistake there, then you are liable. Then your liability increases. Then you have broken the law. That's how it will be interpreted. But on the other hand, not having any guidelines, any records, that that keeps the matter unclear as to what kind of records actually will satisfy the law enforcement authorities. So in general, if the records of our procurement, our stock, our dispensing is maintained in terms of each and every tablet which has entered the clinic can be accounted for, then we are on a much firmer and safer grounds.
Yeah. Alim, I'll just add to that a couple of things. For the NDPS Act, it is Form 7 which is required. The Form 7 says that your stock in and stock out and your daily records need to be maintained. That is a form. It's a very simple form in the sense, but those details have to be entered in that particular form of in the NDPS Act. For the Drugs and Cosmetics Act, it is Schedule H1 in which the details of the patient, the amount of dose which has been dispensed, and although there is no mention about and the duration of course, but there is no mention about identification of the patient, etc., but it is good clinical practice to have the identification ID number, phone number of the patient. These will actually help to show that you have done your due diligence in actually not hiding any kind of details. So if anyone wants to come and inspect the records, one can actually come, call up the patient and say that आपने यहाँ से दवाई ली है, कितनी ली है. So what you're showing is that you're showing transparency and showing that there is no need for you to do any kind of diversion, and the records are open to inspection and things like that. So in the sense, this is more of good clinical practice, but otherwise, Form 7 of NDPS Act, in the NDPS rules, sorry, and of course the Schedule H1 mandates that the records of dispensing need to be kept. What is also important is daily stock in and stock out. So that should match with your dispensing records. So these are the very simple kind of things which are needed. Last two questions, and we'll finish after that. These questions are together, so I will just read them together. One is that can we OST be given for afim addiction? How to do titration of the OST dose, and to be read along with,
We already
yeah,
discussed this. Yeah,
how
yes,
do
it
we
can be given.
increase, how do we increase and reach the optimum dose in multiples of 0.4, 0.8 to very briefly in a couple of lines.
This is important. This is important. Yes,
Yeah.
medicines are available in the strengths of 2 milligram, zero point 0.4 and zero point 0.8. I know 2 milligram is the fixed dose, is the combination with naloxone. So in general, the guideline is that we titrate the dose in multiples of 2 milligram of buprenorphine. So after 8, the next stop is 10. After 10, the next stop is 12. If we determine that 12 is definitely higher than required dose, and if we determine that 10 is definitely lower than required dose. Only then we try to then go through the complexity of finding a middle dose. And otherwise, to for all practical purpose, the dose must be titrated in multiples of 2 milligram. That also makes the life of our dispensing staff or our own easier, because then we don't have to keep different kinds of records for 2 milligram ke liye alag, point 0.4 ke liye alag, point 0.8 ke liye alag. Recently, one particular pharmaceutical company has also received approval for 1 milligram strength of buprenorphine, 1 milligram and 0.25 milligram of naloxone. That approval has been obtained by one company specifically for these reasons, for patients whose requirement is somewhere between 10 or 12 or 12 and 14, those kind of cases. But in general, for all practical purpose, it's 2, 4, 6, 8, 10, 12. That's how we need to proceed.
Yeah. So I will answer this last question. Can buprenorphine be taken out of NDPS Act? I mean, it will be a godsend, but it will not happen.
No, no, no,
My
no, no.
own point, my own, this thing is why only buprenorphine? Please understand, many of our therapeutic medications, which as psychiatrists and as addiction specialists that we use, are in the NDPS Act. So why should we only focus on buprenorphine? There are many, many important life-saving medications which we use. And what is not important is whether they're under NDPS Act or not. But we have to realize that they have a therapeutic use, and that is what many regulators fail to understand, is that they feel that all these medications are only for abuse and diversion, and there is no therapeutic use to that. And that perception needs to change, rather than the fact of whether it is comes under NDPS Act or not. I think with that, I will thank Dr. Atul for a uh, elaborate answering of all questions very, very clearly. Thank you so much. And even I learn a lot of things every time I listen to you. So personally, on a personal note, also I thank you. Now I hand it over to Dr. Lenin if he has any comments, and then to the organizers.
Thank you, Dr. Ashwin. Really, I would like to congratulate and also thank Dr. Atul for giving us such an important insight. And having done justice, today's session is successful. And I would like to thank the organizers, especially Dr. Amit Bhattacharya and Dr. Alim Sadiki. Thank you very much. And also a second chance to chair this one of the series of 171 long series. Thank you very much. And I would like to thank the this one, all the participants also for giving such a beautiful questions and active participation. Thank you.
Thank you, Alim, for the opportunity.
Thank you
Thank
so
you.
much. Thank you to the organizers.
No, sir, it was such a session, such a brilliant session. It was as if the book was talking to us. So thank you for being the book of us and benefiting more than 272 people that were there on this program. Sir, I am handing over to Dr. Tufan, sir, to conclude the proceedings. Amrit, sir, Amrit has left for some emergency, so you have to conclude it.
Yes, I know that I shall complete everything, and that too very shortly, because I don't want to come before your dinner. Thank you, Dr. Atul, for the nice presentation. As nice as expected. So it is, if it is Dr. Ambekar, it is what was expected. And definitely OST is a very good line of treatment, but the acceptance by the public is a matter of concern considering the rate and convenience. The comfort with which you tell that it will be available at this center, people have to come to the center. That is not possible. The comfort with which you tell that a RMP can also disperse it, that is also really not feasible. At least in our place, we don't find. Having known it, no RNP is giving anything, even naltrexone or buprenorphine. No honest. So it has to be led by us, because everyone is worried about the possible side effects. Just having a chair of capacity and telling that you have to choose between constipation and being deprived of these symptoms, or you have to choose between having a little potency problem, that is not well swallowed by the patients. And that too, it is told from the chair of a RMP. So we have to go far, and we have to publicize, and we have to actively educate have to have a strong advocacy for awareness about this treatment. By the time we are successful with this treatment, there may be some newer model will come up because Dr. Atul is working. But whatever is there has to be known to everyone, to all the medical colleagues. Because really as I find, psychiatrists are overcrowded with patients.
Yes.
This may take a backstage. With all respect. And the good news that RMPs can do it. Let us encourage and guide them. So thank you very much for your nice presentation. And on behalf of IPS Research State Branch, I have the pleasure to thank our chairpersons, Dr. Lin Rajkumar and Dr. Ashwin Mohan, who has been for a long time behind screen. Thank you very much.
Thank you very much.
And Dr. Alim Siddiqui and Dr. Amrit, who has gone on an emergency, for being the constant moderators along with me from the very outset.
Thank you
Nice
so much, sir.
evening. And
Thank
thanks.
you. Thank you to everybody.
Thank you.
And
Thank you.
Thank you. Good night.
Good
Have a
night.
good dinner. Sweet dreams.
Sweet
Thank you.
dreams.
Thank you so much, sir. Thank you, sir. Ashwin sir, it brought the best out of you also. It was a very enthusiastic chairperson. Ashwin boss.
Thank you. Thank you. ज़्यादा enthusiastic तो नहीं हो गया?
नहीं, बहुत बढ़िया, sir. It was
Thank you.
very nice. Okay, sir.
Thank you.
In the session with your permission now. Lalin sir,
Good night.
good
Bye.
evening.
Bye.
Thank you so much. Tufan sir, good evening.
Good evening.